with this course, guys, like med-surg, maybe we should make you guys aware, med-surg is a different beast. This is where your ANP, your patho, your physical assessment, your pharmacology comes together, okay? And again, like, we cannot just trim out all of the information and then just stick to the exams, because when you will go to med-surg 2, you will need all of this information to succeed in med-surg 2.
There's another one, I thought there was only one class.
No, and then I think next year you guys have a critical care, which will be all of this, med-surg 1, med-surg 2, and the critical aspects of nursing. Okay, this is what your brain is. Can somebody go get me a napkin, please? For 2 extra points.
Oh, well.
I just need one next week.
You should have one,
What do you
like
need?
a double A.
Oh, like here.
No, triple A.
Oh.
Triple A. Yeah, this one is not worth it. Okay. Okay, so this is your picture of your brain. Get familiar with it, just know your frontal lobes, temporal lobes, your cerebellum, and all that good stuff. I'm sorry, guys, I need to go get the back. It's just like not setting wrong in files. So the brain structure, so we have forebrain, which has what, dicephalon, it has thalamus, hypothalamus, and epithalamus. Okay, and this dicephalon lies below the cerebellum. Where is the cerebellum? Can somebody point? Rama. Cerebellum.
Cerebellum? It's the flowery one.
Anna, can you turn off your camera? Okay.
She's tired, right?
Alright. So with the thalamus, okay, it relays sensation. Okay, the function of thalamus is to relay sensation. Hypothalamus is it controls autonomic nervous system, which regulates your temperature, cognition. Then we have our epithalamus. Epithalamus. It connects the pathways to regulate emotions and your smooth voluntarily movement and functions. Your cerebellum, you have like central cortex, right and left hemispheres. So just for the basic knowledge, your right side of your brain controls left side of your body. Left side of brain controls right side of your body. If you're working with a CVA, post-CVA patient with left-sided weakness, so they have a stroke to the right side, okay, to the right side. And if their right side is weak, then they have a left-sided stroke. So there's something wrong with their left side. So when it comes to your brain, it's kind of like a cross multiplication. Okay. Then we have basal ganglia. I'm not going to go like all the way deep into the A and B. Please read your textbook and your A and B textbook, get familiar with the basics. We have four lobes: frontal, parietal, temporal, and occipital. Okay, just know like where they are located. So your cerebellum controls cerebral function. Okay, this is what I want you to know. Cerebral function. Okay, so what is the function of, what are the cerebral function? If your patient has a cerebral injury, what kind of deficit we are looking for? So let me tell you, so cerebral function is control voluntarily movement, transition from one movement to next. It helps us maintain equilibrium. It predicts distance or gauge the speed with which one is approaching the object. That's right. Thank you. So, if you have a question that your patient has a cerebral injury and you're sending them home, knowing the function, what education will you give to this patient? So first of all, what are we concerned about? Safety, just not fall, safety altogether. Like equilibrium, safety, distance perception, okay, any injury. So we will tell them like not to drive because they do not have the sense to predict distance or the speed at which they are approaching the object, okay? Then we have our brainstem. It includes midbrain, pons, your medulla. It controls your cardiac and respiratory centers, and it helps with the slowing, so de-acceleration of your cardiac and respiratory centers. Okay, your pons, again cardiac and respiratory, but with the acceleration. Think about those tachy, like tachycardia and tachypnea. So your midbrain, it houses cranial nerve number 3 and 4. So what are the functions of cranial nerve number 3 and 4? Eye movement. Okay. Please know all your cranial nerves. And again, like go back to your physical assessment and the function of each cranial nerve. I promise you, you will see it again in the very near future. So just kind of like a basic central nervous system structure and function. So get familiar with just like, we have like ventricles, we have hemispheres, we have brainstem, all that, okay? But like, also get familiar with blood-brain barrier for this class. No blood-brain barrier. What is blood-brain barrier? What's the function of blood-brain barrier? It protects the brain from what? Yes. So it means the blood cannot go to the brain, okay? So this barrier, like any bigger molecules, cannot cross that barrier, okay? So it keeps the substance in bloodstream out of the cerebrospinal fluid circulation. So glucose, your CO2, alcohol, anesthetics, and water can pass through the blood-brain barriers. Bigger molecules such as albumin or anything that can bind to albumin cannot cross this barrier. Okay? So when we are talking about things that can actually cross the barrier, think about glucose. Your brain needs glucose to function. Okay? Glucose is a food for your brain. Okay? Your hypoglycemic patients. What are signs and symptoms? Like what are the clinical manifestations or physical manifestations of confusion? Because their brain does not have the food. Okay? Now think about your hyperventilating patients. Like when there's a buildup, hypoventilating patients, there's a buildup CO2, too much acid. Think about the patient presentation with the CO2. what's happening to their cognition. How about alcohol? It's a vasodilator, it can pass through the blood-brain barrier. We all know what it does. So, then how about anesthetics? Those sedation, when we get concerned about sedation, because anesthetics, analgesics, they can pass through the blood-brain barrier, so our brain can block those nerve paths and the pain. Like, our body will not feel the pain. Then we have what? What is the next one? Water. Of course, we need hydration. Okay, and then we have our peripheral nervous system. So with this picture, this slide, please know your spinal column. Your C-spine, if there's an injury to C-spine, which function you will lose. Okay? And then also get familiar with the terms hemiplegia, paraplegia, and quadriplegia. Okay? So look at the C-spine. If there's an injury to C-spine, what could happen? So if there's an injury to C-spine, your patient will end up with paraplegia, which means loss of function in all four extremities. Okay? If there is an injury from T1 to T12, okay, that will affect your legs, your lower extremities. Okay? And then for the hemiplegia, it's like usually from the stroke. If your patient has a right-sided stroke, then they will lose the function to the left side of their body. So whatever the part of the brain got affected, or the nerve endings got affected, they will paralyze your patient on one side. So hemiplegia is the paralysis of one side, like of one side, one leg, one arm on the same side. Okay. Quadriplegia, so it's like quads, four. It means all four extremities have lost the sensation and the function. Paraplegia, just the bottom half. Okay, so please note the spinal column and the injuries. Like if there's an injury to C-spine, what could happen to your patient? With the T thoracic spine, and same with the lumbar. So about these dermatomes, have anyone ever looked down for dermatomes? Like what these dermatomes are? No? Anyone here had an epidural? Epidural. Okay, so anytime we have a patient with epidural, okay, as a nurse, you need to know your dermatomes, okay? We have badge buddies for that. I'm not going to ask you to remember them, but we'll memorize them. But just know, if there's an insertion site between T1 and T12, okay, you're going to educate your patient like, hey, you're going to lose function and sensation of your lower extremities, try not to get up. What will happen if they will try to get up? They're going to fall. It's a safety risk. And once they have an epidural, what we do, with these dermatomes, we will assess them, moving up or moving down. So moving down, there is, it's an expected finding. If they're losing the function or the sensation below the epidural, that is an expected finding, okay? But if they will start feeling numb going up, let's say, the insertion site is between T1 and T3, but now they're feeling numb, you're kind of touching. When we do dermatome assessment, what we do? We do a touch, palpation, okay? Can you feel my finger, or maybe with a sharp object? Can you feel this? I can. Let's move up. Can you feel this? And usually in ICU settings, we start from the top. If somebody has epidural and they're T1, T2, I would start from the top, okay? Can you feel this? Yes. Can you feel this? Feel this, yes. And then I will stop where they will tell me I can feel it. If it is above T1, okay, then I'm concerned. okay? Because it is, it's going to affect the respiratory system, okay? What is a reflex arc?
Closed circuit of spinal and peripheral reflexes.
Okay? It is not controlled by the brain. Just remember that. It gets sensory input from muscles, tendons, skin, organ which transmits along the afferent neurons to the interneuron, which then send information through the afferent neuron's response. Okay? Please know these last two slides. Then we have our cranial nerves. Please know all your cranial nerves, all 12 of them. Okay? For the testing purposes, you can write down the nerve number and the name on a flashcard. Okay, just like, you know, all 532 is optic. Just for like a quick cheat sheet. Okay? You should not, but it's there. Okay, let's start talking about these nerves, because you will see them again. Cranial nerve number 1 is responsible for what? Smell. Okay, if there is an impairment of olfactory nerve number 1, the patient is at risk for what? Loss of scent. They cannot smell smoke. Let's say if they are like, you know, in a room or like, you know, there's a fire, they will not be able to smell smoke. So again, like it's a risk, safety risk, okay? If they're a nurse, then they're in trouble. Optic sensory, so that's your vision. So how many nerves here control your vision for your eyes? 2, 3, and 4, okay? And right here, right here. And there's like optic, oculomotor, trochlear, and your occlusive, because it controls the lateral movement of eye, okay? Let's say you're working in a neuro ICU, and you're working with a trauma patient, okay? You're doing your assessments, and your patient complains of like, you know, hey, I'm losing, like my eyes are, like my vision is getting blurred. Then we're going to think about these nerves right here, 2, 3, 4, and 6, okay? What about your trigeminal nerve? This is mixed, it's mixed, it has motor and sensory. It's for the mastication. What is mastication? Chewing, okay? For the sensory part, sensation of face and scalp, cornea, mucous membranes, mouth, and nose, okay? So if your patient has impairment of trigeminal nerve, first, guys, like it's very painful, okay? If you have trigeminal nerve, the pain is excruciating. Think about that, like, you know, wisdom tooth, okay? It's kind of like same kind of pain, okay? So if your patient has an impairment of that, first they will be in pain. If they will lose the sensation, then they cannot be able to differentiate like hot or cold. Like, you know, when we're talking about extreme hots or colds. Again, injury risk. Your abducens is your motor. Again, it's for the eye. It controls the lateral movement of your eye. Facial. It's motor and sensory. So, facial muscles, it will help you close eyes, labile speech, closed mouth. So when we're working with our patients, let's say stroke patients, and then they have aphasia or their speech is slurred, okay, we're looking for this nerve, and there's one more nerve, hypoglossal nerve, movement of the tongue, okay? Then you have your acoustic. This is for your ears, hearing and equilibrium. Your glossopharyngeal is for the pharynx also like phonation and swallowing. So with patients with stroke, when they have difficulty swallowing, this is the nerve that is damaged. Your vagus nerve. Can anybody tell me what is vasovagal response? Vasovagal response. Huh?
Gagging?
Hmm? Fainting, yes. So, let me give you a story. One time I lost a patient on the toilet. I mean, my patient coded
Oh, when they're straining.
on the toilet from the straining. So think about when you're pooping, when you're kind of like bearing down. You're activating your vagus nerve. Okay? You're activating your vagus nerve. If you have a bad heart, we tell you not to. For example, if you're running into bradycardia, like, hypotensive bradycardia, we tell you not to bear down. What happens when this vagus nerve is activated? It is going to slow down your heart, your respirations. Okay? Therefore, you're going to pass out. My patient actually died. We coded, but then he fell, hit his head on the floor. So he did not die from the vagal response, but then he died from the brain bleed. That happened. So be very, very mindful. So your older patients, so that's why we get like, really kind of, I don't want to use the word, on top of like constipation. Like for our hospitalized patients, when they're pain medication, if they have fecal, if they will start getting constipated, let's say when they have to go, they're going to bear down, okay? They're already sick, something is already compromised. The last thing I want to do before going home is to hold somebody in the bathroom, okay? So for your patients, again, like vagus nerve, you're working on a cardiac floor, and then your patient goes into AFib or VFib. Okay, by the time they go to VTAC, they are not conscious, they're not going to follow your instructions. SVTs, where they're like super tachycardic, you tell them to bear down. We tell them like, please bear down. And it's like, what does that mean? It's like as if you're pooping, okay? Just bear down. So what we're trying to do, we're trying to activate this vagus nerve. We're trying to trigger this vasovagal response to slow their heart down, okay? Your spinal accessory, it is movement for your trapezius. So how do we assess it? Shrug your shoulders. Okay, you're doing an assessment and your patient is having difficulty. They can't feel. We are concerned about spinal accessory. So when you're assessing spinal accessory, you will tell your patient to do what?
Shrug your shoulders.
Yeah. Hypoglossal. Move it up the tongue. Take your tongue out. Say ah. Okay, guys. Please get familiar with your cranial nerves. Just for the test purposes next week, I don't know, like I should, but then there's lots of information. Just this part right here. You can have it on your index part. Okay? Then we're going to go into our autonomic nervous system. Sympathetic nervous system. It starts from at T1, goes down to all the way to L2 and L3. It is responsible for what? Fight or flight response. What is fight or flight response? Give me the clinical manifestations.
Increased heart rate.
Mm-hmm.
Low dilated pupils.
Sweating.
Increased respiration.
Bronchodilation.
Mm-hmm. Why bronchodilation?
To allow more oxygen.
Allow more air. Okay. What else? Pupils. So think about fight or flight. In this situation, your body is trying to keep you alive. And what are your vital organs to keep you alive? Your heart and your lungs. Okay? So yes, you are tachycardic, you're hypnic, okay? And guys, you're in nursing school, you're constantly in fight or flight. How many of you guys are constipated all the time?
Oh my god, that was because of that? No shame, no comment. Really?
Or, you know, or the other way. So fight or flight is your body.
Depends if you have exam or not.
So fight or flight is your body's response to protect you or just barely keep you alive. Okay, so think about tachycardia, tachypnea, and some of the bodily functions will be impaired because your body is trying to keep you alive. It doesn't care about anything else. Okay, you will have heightened sense of like vision. You will see things clearly. Maybe you will hear things. Your heart is pumping. Your lungs are inflating, but maybe the rest of the system might not up to the speed. What is your sympathetic nervous system?
The opposite.
Rest and digest. Think about post Thanksgiving dinner. Okay, now what happens? So this again, like, you know, after, let's take an example of your, like after lunch when you come to class. Nobody's in fight or flight, because we had a meal and all the blood is going down to the gut. Nothing is going up to the brain here, okay?
Wow.
Because right now the priority is what? To digest this food, okay? So it's kind of like feed and breathe, rest and relax, okay? So with the peripheral nervous system, parasympathetic nervous system, it conveys motor commands to all voluntarily striated muscles in the body. It carries sensory information from environment and body to the brain and spinal cord. So this is like where you're relaxed. Page 838, neurological changes with age. So your motor function is slower, and your time to respond to any triggers or stimuli is also slow. Decreased sensory perception. So in this case, like, you know, and it's a normal finding. Again, it is a normal finding. Okay. Sensory changes, your pupil size decreases. Touch sensation decreases, and less vibration sense. Okay? Now, think about, like, since we're going to talk about delirium and dementia, so let's get familiar with the cognition part here. Cognition function. So intellect does not decline as the result of change. Okay? They may need more time to process new information, a new skill. It does not mean they have lost their marbles, or they're like retarded, or they do not have cognition. It is just they need more time to process things. Okay? So when we are educating our elderly clients, okay, we want to make sure we slow down. Okay? If we have to repeat ourselves more than one time, please do so. Because it is not, they're not understanding you, it is just they are processing it on their own pace, and it's a normal finding. Okay? Then they have a cognitive decline, frequently caused by drug interactions, toxicity, inadequate oxygen supply. So think about hypoxia or anoxic brain. Hypoxia is like what? When your brain is not getting enough oxygen. Anoxic brain is where there is no oxygen. So kind of like going sidetracked from aging to like anoxic brain. So let's say your patient is like in a bar fight. Again, like it actually happened with one of my patients. Your patient is in a bar fight, okay? And they had, let's say, like a knife. There was like a knife wound to their jugulars, okay? And by the time this patient came to us, like there was like no other wounds, like no head trauma, nothing. Just like a slit and gushing blood. So by the time this patient came to us, yes, we were able to save his life, but then he lost some blood, therefore he lost what? Oxygen going up to the brain, and then he ended up with anoxic brain. A 25-year, he was 24 years old, but then he lost all his cognition, like, he was confused, delirious, couldn't feed himself, couldn't walk, he pretty much lost all the functions. He was awake and alert, that's a different story, okay? But then again, just think about, like, yes, he was like losing blood, but then blood is carrying what? Oxygen to your brain, and if that loss is tremendous, and your patient is out in the field for quite a while, we can replace the blood, we can replace the volume, but we cannot reverse the anoxic injury. So just remember that anoxic injuries are irreversible. If your patient has anoxic injury and then they have lost a function because of anoxic injury, they can never, ever, ever recover that function again. So your elderly patient right here, they have long-term memory better than their short-term memory. Okay? Again, it may take them longer to retrieve that memory, to retrieve that information, because they have lost some of their cerebral neurons. Biorhythms. How many of you guys work in like long-term care, like working with elderly patients? So their circadian rhythm is like not up to date. They wake up super early, or maybe 3 o'clock, 4 o'clock in the morning, and then they go to bed what?
Like 4 or 5.
3, 4, 5, you know? And, but then again, like, they still need sleep. So if you have an elderly patient with a messed up circadian rhythm, like they cannot tell their day from night, encourage nap time in between for them to relax and recuperate. Okay. They still need about 6 to 8 hours of sleep. Mental status, it may be impaired by infection, hypoxia, hypoglycemia, or hyperglycemia. So just going back to, like, your blood-brain barrier. Okay, and decrease of change in mental status is the key early sign for infection. Let's say you're taking care of like a 99-year-old cute Mary Jane. Do we have a Mary Jane in the class? I'm sorry. No, I don't. No. And all of a sudden she is delirious, she is confused, okay? Maybe she's agitated, she cannot tell, like, left from right, she forgot where she is. It's very acute, okay? What I'm suspecting here?
UTI.
UTI. Maybe she has some, like, maybe just like necessarily not UTI, but like she has some sort of infection going in her body, okay? In elderly, the change in their cognition and their mental status is the first sign for infection. So that's when we kind of like do lung assessments, make sure she doesn't have any pneumonia going on, maybe the UA, blood cultures, just to make sure we're not missing anything. Health promotion and maintenance. Prevention is the key. Avoid risky behavior. Practice healthy lifestyles. Okay, so younger adults, especially male, are at higher risk for spinal cord injuries or head traumas. Okay, and again, if there is a patient, avoid alcohol and other substances that can impair your judgment, because alcohol can cross what? Blood-brain barrier. Those sedatives, those analgesics, they can also cross your blood-brain barrier, and then they can impair your judgment, and therefore what happens? You are a safety risk for yourself and everybody else around you. Do not smoke, because smoking can cause vasoconstriction and can cause decreased perfusion. you will be hangry. I get hangry. That's like when my brain does not have enough glucose. So you will have impaired judgment, and you're at risk for what? Safety risk to yourself or others. Like my partner, he gets like worried when I get hangry, because then he acts like very quickly, because he's at risk, his safety is at risk. I'm not violent, it's just I get very fat. Regular exercise is also vital. Okay, then you have assessment, noticing, and interpreting your data. Patient history, okay? Patient is the best source. Let's say if you have a question like in your CMS or NCLEX or like maybe somewhere, like you're working with a patient who has dementia, okay? Has a history of dementia, but right now they are alert and oriented, and they're giving you all the information. Still, in this case, your patient will be your best bet to get the data, because they have a history of dementia, right now they're alert and oriented. If you do not see assess any impairment into their LOC and their cognition, your patient is the best source to get health history. Unless they're confused, they're comatose, or we're coding them. Okay, in that case, you can rely on a caregiver, a friend, a family, whoever is available. But your patient is the best and the most reliable source for information. Then we do physical assessment. Check their like baseline neurological status. So why do we do baseline physical and neurological assessment when we meet our patients? Why that baseline assessment is important? So you have something to compare with, okay? So that's why we emphasize on that admission assessment. As soon as you lay your eyes on your patient, please do your assessment, okay? If you have missed that window, and let's say like maybe 30 minutes later, your patient is different, there's a change in their condition, you have nothing to compare this change with. So please always, always, always do your baseline physical and neurological assessment. So guys, I'm taking my sweet time on this chapter because the next chapter, delirium and dementia, it's pretty much like a repetition of this information. We will just kind of like build family education, patient education, and then, some interventions that we can put in place. So for assessment part, diagnostics, please pay attention to this chapter, okay? So then we have complete neurological assessment. It is, the complete assessment is usually done by a physician or advanced healthcare provider, your NPs or advanced practice nurses. So when you did your physical assessment class for the neurological, that's what complete neurological assessment looks like, okay? But from the nursing standpoint, we do a very focused nursing assessment. And that is just kind of mental status, LOC orientation memory, and then maybe PERLA, that's what we check. We check for gag reflex. We just kind of check their range of motion. This is like a basic and focused nursing assessment. Complete neurological assessment is done by your physicians or the advanced practice providers. So within the complete neurological assessment, we assess for the mobility, for the motor system function, assess for deep tendon reflexes and sensory perception for the sensory function. So while we're doing this complete assessment, we're assessing for any asymmetry from one side to another. Whenever you're assessing your patient, make sure you're assessing bilaterally, not just one side of the body. And if you have assessed their left arm, right arm, make sure you're going to assess their left arm right away, okay? Not like, let me just kind of complete the left side first and then I will move on to the right, okay? We're doing bilateral assessment. So for like, why are providers, they do complete neurological assessment? to assess for lesions. Okay, so when we do this, when we do this complete neurological assessment, we will be able to tell, like, you know, if all these deficits are from a single lesion or maybe multiple lesions. So maybe the severity of your patient is, the acuity of your patient is higher. And complete assessment determines the treatment and the urgency of the situation. So again, just remember, complete assessment is completed by the physician or the advanced practice nurse. Mental status. Your LOC, orientation, and memory. Assessment of consciousness and cognition. So consciousness is what? Level of consciousness. What does that mean?
Their alertness.
Their alertness, okay? We are checking their alertness, their engagement. If they're awake, that is normal. If your patient is comatose, lethargic, or stuporous, that is abnormal finding, okay? We will talk about the GCS screening. So for that, please remember your LOCs, okay? So after determining their like alertness, their LOC, we will check for their orientation, okay? So what are the questions you ask your patient for the orientation?
Place, time, person,
Mm-hmm.
situation.
Mm-hmm. Just kind of like, you know, very recent. So what are the three like main questions we ask our patient? Tell me your full name, your date of birth, what is the day, what is the date,
Where are you?
where are you,
Why are you here?
why are you here, who's the president? I don't get into politics. Alright, so, so when you're doing your, LOC, your, assessment, link any changes in cognition, in their LOC status, determine the root cause. Okay, for example, sundowning, your patients with what? Dementia, okay? There will be a change in their LOC orientation and memory, okay? Delirium, your patient like, you know, hospitalized for a long time. Now they're losing the sense of what? Time and day. So you will find some confusion in your hospitalized patient as well, okay? And every patient who is admitted is at risk for delirium, okay? Meds, any medications? Think about your sedatives, analgesics. Sleep deprivation, and also check your blood glucose. So before you jump and start assessing your patient for stroke, unless there are visible signs, okay, please check their blood glucose first. If you can rule out dementia or delirium, check their blood glucose. Maybe they're just hypoglycemic, their brain does not have enough food to function. So with the cognition, okay, that is the memory and attention, okay? So your mental status, LOC, is just alertness. And with the cognition, it is the memory and the orientation. Okay. Acute memory impairment is an early sign of neurological impairment. So if there is like your patient was fine and all of a sudden like they're confused, they're delirious, okay, and they cannot recall information, like, you know, any long-term, short-term information. They're agitated, distracted. That is the sign of any neurological problem, especially in your elderly clients. So think about UTIs or any sort of infection. So how do we incorporate cognition assessment? So we have checked for LOC and orientation, level of consciousness and orientation. Your memory is your cognition. How do we assess for that? Yes, so again, so the one thing is like in your textbook is assess their language skills. understanding of the written or spoken words, okay? And how, if they're following instructions, if there is a language barrier, okay, then we can point at things, okay? To tell them, like, tell me what is this, okay? Or like what I'm doing. Like, please don't do jumping jacks, okay? Then we have our cranial nerves, so please know I did talk about this, please know your cranial nerves and the functions and the impairments and how to assess them. And the impairments, look for the abnormalities. Motor functions, so this is where we will learn, like assess their motor function and then find out if the impairments are related to their cranial nerves or their neurological status. So there are like two terms in your textbook. Decortication, this is kind of like the inward movement, like, you know, where your arms kind of like come in, your feet kind of do like internal flexion. So the key word is core, decortication. So core, everything is moving inwards, right here, see? This is your decortication. Everything is moving towards the core. Okay, so this is because if there is any lesion that interrupts their cerebrospinal pathway, and your patient, like, and everything kind of like moves inwards. Their feet are flexing internally. Then we have like the separation, and this is where the contracture is kind of like away from the body. So if you know your core, everything is going in. And the other word will automatically tell you like everything is going away. So these are like, just like the two, and then right here, when we tell them to kind of move their hands, like, you know, up and down together, so let's say, like, you know, if they can only do like one hand, or like they don't have the coordination, it's kind of like going like this, okay? It will tell you some sort of like a lesion or like an interruption in their cerebrospinal activity. Then we have our reflex activity. How many of you guys are familiar with the DTRs, deep tendon reflexes? Okay. Babinski sign. Right here, guys. This is like one of the reflexes that we assess. Is it normal or abnormal? Abnormal. But it is also normal
In kids.
in babies. At the age, it is normal until the age of what?
2.
Until they're 2, okay? After that, it is abnormal, okay? That's why when you're doing our assessment, if your patient has a positive Babinski reflex, it's an abnormal finding, okay? And when we have an abnormal finding, as nurses, we are like little spies, we want to know all the answers. So you can check, like, you know, why this reflex is abnormal. Do they have any neurological disorders? Or any drugs, alcohol, post-seizure. It is normal, like, you know, your patient has a seizure disorder, and then you check their Babinski. After a seizure, you will find, like, you know, they might have a positive Babinski reflex. Okay, MS or in severe liver disease. Then we have our sensory function. So what is the primary sense in nursing that we're always checking for when you're managing? Starts with P. Pain. So, pain starts with P. I was with the ACA, there was some glitch in the system, and then they asked me, oh, tell us the answer for your questions, and first I forgot what my questions were, and then she gave me like, these are your questions, and like one of them is like, I don't have a favorite food, but for some reason I pick it and it's different all the time. So I just put something weird there, she's like, it starts with P. And then I picked something. Pain, okay. So pain perception. okay? The touch sensation and the ability to discriminate. So let's say you're doing your assessment, your patient, and then when you guys were doing in your physical assessment class, so your professor must have had you kind of like, cotton tip applicator and the sharp end. Okay, what do you feel? Dull or sharp? Dull, sharp. So if there's a neurological disorder or problem, you will use that discrimination, that ability. Okay, and when you're doing the neurological assessment, you're constantly asking our patients, like, can you feel the touch? Okay, the touch sensation and the perception. So if you lose that, there's an impairment into their sensory function. Cerebral function, so again, your safety, if there's an impairment in their cerebral function, we're thinking about the safety here, okay? So your patient will have issues with fine coordination of the muscles, okay? So right here, this is what we're testing, okay? Run your heel on your shin, okay? When we're assessing, what is the normal finding? So it's like, take your heel, able to do it, but like, able to do it like in what fashion? Okay, so they should just kind of like follow their shin straight. If they're kind of like going like this or going like that, it's like not a straight line, so they're like not able to follow it, then there's a problem with your fine muscle coordination. Okay. This is your GCS, and this is what we do as nurses. Rapid neurological or focused neurological assessment, okay? Again, in emergent situations, we are doing it all the time. We do neurochecks, done in emergent situations and also like frequently. So with your patients, again, like does not matter which setting you are in, ICU, med-surg, long-term care, SNF, you're always assessing, doing this like focused neurological assessment, because if you are missing this, if there is a change, a prominent change in your patient's condition, you will not be able to pinpoint it, okay? You have nothing to compare this data with, okay? So for our glaucoma scale right here, there will be a test question, guys. So please know where we get worried. So when we are doing the GCS, we are checking for their eye opening. Is it spontaneous? Do they open their eyes to the sound? Like, if I call, like, hey Morgan, and Morgan responds, but your eyes were shut. When I say Morgan, he opens his eyes. Yes, you did. So, to sound only, okay? Let's say, if it's spontaneous, it's like, your patient, like, they're just kind of like looking around. To pain. So, first we will start with the sound. Okay, I will call the patient's name. They have not responded, they did not open their eyes, then we will go to the pain. For the pain, guys, like we can do like what? Like touch them, sternal rubs in most cases, or kind of like press on their like nail bed, okay? So with our patients like on life support in ICU, like those comatose patients, like we are, like even our patients are comatose, we are still doing this GCS assessment. So you take a pen, okay? Put it on their nail bed, if you can do it on great toe, you can do it anywhere, and then press it really hard, okay? If your patient will not open eyes, fine, but like if there's like a flinch or reflex, okay, that counts a bit. So you can give them like what? Maybe two, but like eye opening is the must, okay? Let's say you did, like they are not looking around, they did not open their eyes to sound, they did not respond to pain, you did a sternal rub, whatnot, you will give them one. Okay? You will give them one. Then we check the motor response, obeys commands, okay? It's like, Morgan, open your eyes. He opened his eyes. And you raise your left arm. He raised the left arm. He's following instructions. Okay, so I will give him 6. If he will not, I will move down. Okay? So, sorry, like with the motor response, when I talk, just like pen, like pressing the pen on the nail bed, So, again, if your patient can like pulse away from this painful stimuli, you can give them 5. Like my patient is comatose, but like, they responded to the painful stimuli. In 99% of the cases, they don't. Normal flexion, which is withdrawal, abnormal flexion, extension, or none, right here. This is your flexion, withdrawal, okay? This is abnormal flexion. This is extension. So if there is none, we give them 1. Verbal response, they're oriented, okay? We give them 5. If they're confused, we give them 4, but they're still talking, okay? Inappropriate words, like, those like patients with stroke or whatnot, they have a word salad. It's like not very coherent, it's not making sense, okay, but they're talking. Okay? Incomprehensible sound, just kind of like babbling. Like, like toddlers, when they do, like just make sounds, but then it doesn't mean anything. Okay? And if there is no sound, we give them 1, okay? So the highest possible score is 15, okay? After 15, let's say by 13, we are good, okay? But if it will start dropping below, like less 10, we are worried right here. This is the patient you're going to pay more attention to, okay? All you need to know, what are the assessment components for this GCS scale? What are we assessing? How are we assessing it? What is the highest possible score? What does that mean? It means there's no impairment for this patient on the neurological end. But if this score will start going down, and then you will see like where it's going down, and then you get worried.
Coma starts at like 7 or 8.
Or below 7.
About like 8. Like even at 8, you're worried about your patient. Then we have our psychosocial assessment. Okay, so response may vary depending on whether patient's condition is acute or chronic. So let's say, like, if your patient have a stroke and then they don't have any long-lasting disabilities, okay, they're not at risk for any psychosocial issues. If your patient has a stroke and now we are sending them home with long-lasting disabilities, like where they might not be able to eat by themselves or dress themselves or like, clean themselves up, okay, you're going to assess for what psychosocial issues right here, okay? The role, strain, their economic status, their employment, and also depression. Like if they're losing control of their life, this is where we do the PHQ-9, depression assessment. Consider cultural and spiritual background. So with the cultural, like your patient has a stoic effect and this is kind of normal, they're not going to express pain or anything, we can start looking into other areas. Okay guys, now this slide is very important. Diagnostics. For the labs, so for these patients, for neurological status, we are doing what, BMPs, okay? For the BMPs, what are we checking? Their fluids, electrolytes, okay? Like mag, calcium, phosphorus. CBC for anemia. Now think about it, if their hemoglobin, hematocrit is low, what's happening? They're not getting what? Oxygen to their brain. You're checking for albumin, their your metabolic panel, like, albumin, minerals, and vitamins. So albumin is what? For malnutrition, when we're talking about vitamins, we are focusing more on the B vitamins. ABGs. We're checking for their pH, O2s, their CO2. Excess or depletion can contribute towards neurological impairments. So let's say, like, with this is kind of like, this, when we're talking about ABGs, I only mentioned pH, O2, and CO2. So what kind of imbalance we're looking for? Metabolic or respiratory? Respiratory, okay? Because what CO2 can cross the blood-brain barrier, BBB, okay? Imaging, cultures, okay? So the cultures are done to identify pathogens causing infection. In pre-existing neurological disease, blood-brain barrier is not intact. So pathogens can cause infections because they're able to cross this blood-brain barrier. The examples are what? Meningitis and encephalitis. Then you're going to move down to the imaging, just the plain x-rays, okay, of skull and spine. So we are going to diagnose for what? Fractures to the spinal curvature, bone erosion, dislocation. So in trauma situations, assess and stabilize their ABCs first before you throw them for any diagnostics. So stabilize their ABCs first. Make sure they have a clear airway, they're breathing, they're hemodynamically stable, okay? And then we can stabilize their spine if there is like an indication of head trauma or C-spine injuries. And then we can rule out spinal fractures, trauma to the head or spine. So when you're sending your patient for x-rays, it is non-invasive, okay? Remain still. And there are like no special post-procedure follow-ups. And then also what? Like any metal objects that they have on them. We ask them to take it off. Then we have our cerebral angiography or arteriography. It is done to assess the cerebral function circulation and to detect any blockage. It is also done to check for aneurysms, any traumatic injuries, and tumors. Any AV malformations, which is your arteriovenous malformation. You guys want to take a break? 5-minute break? Okay. I saw your score after I logged out.
I'm not a stay long. Because I have
Can you throw? Oh, do you want me to stop this?
Oh, yeah.